Hello, everyone. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about hypertension. Now, hypertension is one of the most prevalent conditions in the world. It is really important to understand, I guess, a bit about why we get hypertension, having a brief understanding of secondary causes, and then very obviously knowing how to manage hypertension, both from a pharmacological as well as a non-pharmacological way. You will almost always get a few questions on antihypertensive medications. And these are medications that you're going to be very familiar with over the next few years. So starting off nice and easy, how common is hypertension? So it's one of the most common conditions affecting about 1 in 3 adults. So probably someone you know almost certainly has hypertension. A good, I guess, idea to know in terms of hypertension is what actually constitutes a hypertensive diagnosis. So what blood pressure would be considered hypertensive? Now, there's been a bit of a debate over the past few years. Traditionally, the world has followed the guidelines set out by the American Heart Association, which until recently, a few years ago, was 140 on 90 was the threshold. Recently, this has been dropped to 130 over 80, and therefore, this is what I would recommend going with. However, it's still worthwhile knowing that many other associations like the Joint National Committee still have 140 on 90 as their cutoff for hypertension. In terms of what does this change, obviously that would mean that a larger pool of people might have hypertension. However, based on the current guidelines by the RACGP, our thresholds for treating hypertension haven't changed significantly. So it's more of an epidemiological change and more so trying to tackle the issue as early on as possible to obviously prevent some of those long-term complications that we'll talk about in a second. The next question being, what actually causes hypertension? Now, that's a really good question that a lot of people have been trying to answer for decades and decades. The two broad types of hypertension include obviously primary hypertension, secondary hypertension, and primary hypertension being more common than secondary, as you can imagine. The exact answer to what causes primary hypertension, which is most of the hypertension you would see in your life, is that there is no specific answer. And that can be quite challenging when explaining that to your patients, because patients would often want to know, well, doc, why is my blood pressure high? You know, I've been eating the same thing as my husband and he is completely fine. Why is my blood pressure fine? Or something down those lines. So it's really important to explain that there's no known exact etiology. However, we know of many factors that can contribute to a person's risk of developing hypertension. These obviously include everything that fits under our metabolic syndromes. So high cholesterols, high BMIs, circumferences, body mass percentages, levels of activity, smoking history, family history, and so on. So it's really hard to give a straightforward answer. Secondary hypertension is the one I particularly like. Although it's rarer than primary, it's really a riveting field of study because although it's not as common, the causes of secondary hypertension, if detected, many of them can be treated early and we can have great results. It's also important to know that many causes that you can see listed here cause really bad or malignant hypertension, which is going to have comparatively worse outcomes. I like to think of secondary hypertension as the systems whose etiologies might cause hypertension. So starting off with renal, which is one you'd quite commonly see. So renal artery stenosis is a big one. The ones I've highlighted in red are ones you should definitely know a bit about and always consider in the back of your mind. And I'll go through why each one of those 3 red points is important. So renal artery stenosis is really important to know. Just remember that for a second. PCKD or polycystic kidney disease, another one to consider. In terms of endocrine causes, primary aldosteronism, or commonly called Conn's disease, is a very, very big cause of secondary hypertension and is considered to be the leading cause of secondary hypertension. Now, this is a really interesting one, and it's one that I've studied and done a bit of research in. The really exciting thing about primary aldosteronism is, well, as with anything, there are a few good things and a few bad things. The bad things are that we are not looking for this condition. Because we often expect hypertension to be primary, we aren't often examining or looking for other causes. The good news is that we can test for PA or primary aldosteronism with a very simple blood test called the aldosterone to renin ratio, which would be elevated because in PA you have high levels of aldosterone, which suppresses the renin. It can also be very easily treated and often has incredible results, either through a medication that blocks that excessive levels of aldosterone, and that would be a mineralocorticoid receptor antagonist, something like spironolactone, or if you identify an adenoma in the adrenal glands, which is the other broad cause of it, you can simply go out and surgically remove that adenoma or the gland itself, and it has incredible outcomes. Cardiovascular causes to consider would include coarctation of the aorta, which is a rare one, as well as obstructive sleep apnea. OSA is a bit of a tricky one because you don't really expect it to be there, right? The exact association of OSA with hypertension is not one of direct causality, but people who often have OSA also do tend to have hypertension. Two reasons. Firstly, people who develop OSA tend to be of a larger body habitus. That's one reason. The second reason is with OSA, you often have a wave of desaturations over the course of the night, as you would know. So because you stop breathing, you have apneic episodes and your oxygen saturations drop. Because of those repeated periods of hyposaturation in your basic bloodstream, you end up developing a reflex hypertensive picture, and that often ends up developing into a actual hypertension, which lasts the entire day, and that's often months to years after the first episode. In terms of medications, very commonly taken medication, NSAIDs or ibuprofen, can cause hypertension because of its interactions at the level of the kidneys, and also stuff like steroids as well as illicit medications. Now, why are these three causes important? I talked briefly about why PA is important. Renal artery stenosis is important because when we treat hypertension, we often give something called an ACE inhibitor. And that can often, the basic function of an ACE inhibitor is to act at the level of the renal arterioles. However, if someone has renal artery stenosis, that can often be a real detrimental factor and can cause to acute kidney injury in the short term. Therefore, it's definitely something we want to rule out before we start patients on medications. The second one being NSAIDs. Now, NSAIDs, again, because they act at the level of the kidneys, we always got to be aware because, as you know, chronic kidney disease is both a cause and effect of hypertension, and therefore we want to advise patients to be taking as little NSAIDs as they possibly can. So that's another, I guess, value point when you see patients. So how does hypertension actually present? Now, unlike many other conditions, you probably know that hypertension is known as the big silent killer because obviously patients with hypertension don't present usually with symptoms of hypertension itself unless the hypertension is quite bad. So therefore, I ask you to think of hypertension presenting in two broad ways. First, we have if hypertension ever really got that bad, you could have signs and symptoms of the actual hypertension, which would often mean that there is something called a hypertensive crisis, which can have really, really detrimental consequences. The second being over time, the high levels, the high blood pressure is going to lead to some complications throughout your body. So it's important to screen for those. And if you identify any one of them, to go and look for hypertension and treat it accordingly. So starting off with what a hypertensive crisis is, it's when your blood pressure is above 180 on 110. This is quite bad, as you can imagine, and is often seen with secondary causes. You can also have symptoms of end organ damage, which I've described below here. The high blood pressure itself can cause headaches because of high blood pressure in the cerebral vasculature, dizziness, as well as epistaxis. If you imagine a plumbing system that's so high pressure, it's going to be way more likely that you're going to have leaks and bleeds from various places. On those same lines, you can end up having hemorrhagic strokes if any of those cerebral arteries burst. You can have hypertensive encephalopathy, which is more so micro-injury and microvascular damage throughout the cerebral architecture. With the eyes themselves, obviously, your retinal arteries are very sensitive, and therefore, with high blood pressure, can cause long-term damage as well as papilledema, which is increased pressure. And lastly, with renal complications, you can also end up developing acute kidney injury or chronic kidney injury too. In terms of other long-term complications you need to consider, chronic kidney disease, as I already mentioned, being a renal complication, you can end up with left ventricular hypertrophy. If you think about it, the high blood pressure is in your systemic circulation, right? And the big pipe that's leading into all of that is going to be your aorta. Now, if the aorta is facing a lot of resistance, or your left ventricle, which pumps blood into the aorta, is facing a lot of resistance because of that high pressure, it's going to try to overcome that by becoming larger in size. And that's where you end up with left ventricular hypertrophy. You can also end up with hypertensive retinopathy, which is just a complication of the retinal damage that I talked about with the acute eye complications. The next big question is, when do we actually treat hypertension? When do we look for it? When do we treat it? So although this is not exactly third-year material, I think it's still good to have a broad assessment or idea about. I've taken this from the RACGP guidelines for hypertension management for Australia. So the first thing you need to do is you want to calculate a person's cardiovascular risk. Now, there's an online calculator, the link to which is right here. Once you do that, it basically stratifies you into a high cardiovascular risk, moderate, or low risk. What you always want to start with is going to be, are you going to be your lifestyle changes? And that's SNAP-W, which I'll get to in a second. And based on which group you fall in, you're going to have different thresholds for treating that, right? So if you only treat hypertension pharmacologically in the low risk group, if they have a blood pressure above 160, as you can imagine, this is quite high, right? However, those thresholds keep dropping as we go into a higher risk. That's something worthwhile knowing. I don't think you need to know the specifics of what the numbers exactly are. In terms of SNAP-W, this is something that's going to come up time and time again. So I would highly recommend that you familiarize yourself with them quite well. So SNAP-W is a very handy acronym that stands for smoking, which you want to stop, nutrition, which you want to have a low salt, hopefully, low salt diet, minimizing fats, excessive sugars. You can refer them on to a dietitian if you suspect that they could improve their diet and lose some weight, perhaps. Obviously, reducing alcohol consumption is ideal, and we want to keep that to less than 3 standard drinks per week, less than 3 standard drinks on any day for a man and 2 for women. In terms of physical activity, obviously promoting exercise is ideal, and weight loss as well if they are overweight or obese. The next question is, okay, Karan, now we know that lifestyle changes have not worked and we want to start them on a medication. So the question arises, of the many antihypertensive drug classes that we know of, what do we actually start them on? And the broad classes, for those who might not be familiar, include firstly our ACE inhibitors. We have our ARBs, or angiotensin receptor blockers, which have a quite similar mechanism of action. We then have beta blockers. We then have a broad range of diuretics, which would cover loop diuretics like furosemide, thiazide diuretics, as well as potassium-sparing diuretics like spironolactone. We can also have calcium channel blockers, which may be dihydropyridine or non-dihydropyridine based, and those include your amlodipine, diltiazem, verapamil, and so forth. And then we have many new and upcoming drug classes like alpha blockers and monoxidine as well, which is really up and coming and really new. So your go-to first-line choice is almost always going to be either an ACE or a calcium channel blocker or a low-dose diuretic. So pick one of those 3. In practice, you would almost always start with an ACE inhibitor or an ARB, or an angiotensin receptor blocker. The reason to make that switch is a very common side effect of ACE inhibitors is a dry cough, because of the effects of ACE inhibitors on a certain enzyme called bradykinin. That can lead to a dry cough. However, ARBs, or angiotensin receptor blockers, do not have that side effect. So that's something to consider. Once we do that, we want to review them in a few months. And then if that dose is not reached, we then add a second agent. So we try to combine these 3 medications in some way or the other. So if you already start them on an ACE, the 2 broad options we have is, well, do we add a calcium channel blocker or do we add a thiazide diuretic? Here's a really good table indicating what combinations have been proven to be more efficacious for certain demographics. So you would see that adding a calcium channel blocker to an ACE is better for those with diabetes or lipid abnormalities, while thiazides would be better for someone with heart failure or if they've had a stroke, versus a beta blocker, which might be useful if someone has had a myocardial infarction in the past. So although it's not really a contraindication to use one over the other, it's really good to know of what combinations are efficacious for certain groups. And then obviously, if you don't reach that dose, you might consider adding another medication. But then another thing you want to also consider is changing dosages. So broadly, what you want to do is first add the first medication. So let's start with an ACE. Then let's say we add a calcium channel blocker. Then we increase the dosage of the ACE. We increase the dosage of the calcium channel blocker. These are all individual steps. If nothing gives, you then can add a beta blocker on top of that. A thiazide on top of that. So you go for an ACE, calcium channel blocker, and thiazide all together. If nothing gives, then that is hopefully not going to be your problem, and they might require additional testing to screen for secondary causes, and probably would need an endocrinology referral at that point in time. Some good points to know to wrap up about each antihypertensive drug class, and these might come up in exams, but it's also good to know when you're explaining medications to patients. So ACE inhibitors end with pril. So perindopril is a very common one that you're going to encounter. They're really good for ischemic heart disease and diabetic nephropathy. So if you ever encounter a patient with diabetes who has hypertension, your go-to first-line medication is almost always going to be an ACE inhibitor. The most common adverse effect I talked about is a dry cough and hyperkalemia. And that's important to know because spironolactone can also cause hyperkalemia, which is why we are often careful using the two together. Another rare complication is angioedema, which is a reactive swelling, quite commonly of the face, and you would warn patients of that. Also know that you should never ever add an ACE inhibitor to a diuretic to an NSAID, because that forms the triple whammy for renal failure, and your patient will have an AKI, which obviously you do not want to happen. In terms of investigations, you want to do a baseline UEC first to look at their potassium levels, which you repeat in 1 to 2 weeks. And obviously, you would not use this medication if someone had bilateral renal artery stenosis. ARBs end with a sartan, so irbesartan, candesartan, similar to ACE inhibitors, but do not have the dry cough. With your calcium channel blockers, your amlodipine, nifedipine, quite commonly used, they are quite good for, I guess, a second line, but also good for pregnant women. You do not use ACE or ARBs in pregnancy. One of the adverse effects to know is peripheral edema, and they can also cause reflex tachycardia. The reason that happens is, as you can imagine, with falling blood pressures and peripheral vasodilation, your heart may detect that and kick on to balance that out and cause a reflex tachycardia. It's also important to know that your non-dihydropyridine calcium channel blockers like diltiazem and also verapamil do not cause the reflex tachycardia because they act more centrally at the heart. With your thiazides, great medication, good for heart failure. Do not, or be careful giving them in hypers. So they can cause hyperglycemia, they can cause hyperuricemia. Thiazide is a leading cause of gout, can also cause hyperlipidemia. Beta blockers are good for heart failure and post-MI, but they're never used first line. It's important to know that they can also cause bronchoconstriction, so you want to avoid them in asthma patients. How does all of this fit in, I guess, in your clinical years or in exam questions? Well, quite commonly, you'll be presented with the stem of a patient who might have some of these factors. And your basic job is going to be to nitpick, well, I can't give this one because of this, I can't give this one because of that. I know this one would work better for them, and that's how you would arrive to your answer. There is technically no right or wrong order, but there are going to be certain preferences. So to give you an example, quite commonly, they might ask, you have, let's say, a 45-year-old female who has had hypertension that has not responded to your SNAP-W treatment. she has a history of gout and also has asthma that is being treated with a puffer. What are some medications that you would like to give, and what order would you consider? Well, you know that she has, so our first line medications are obviously going to be either an ACE, a calcium channel blocker, or a thiazide. If she's had episodes of gout, we want to avoid the thiazide for now. We also know that she has asthma, so no beta blockers for this woman. That leaves us with these three. So ACE, ARB, and amlodipines, dihydropyridine calcium channel blockers. So we'll start her off with an ACE, mention the dry cough, mention the fact that we might require to follow up her blood work in 1 to 2 weeks, confirm that she's not pregnant. If she has a dry cough, switch her on to ARBs. If her blood pressure doesn't improve in 1 to 2 months, add on the calcium channel blocker, and then you might consider manipulating the doses of each one of them, right? Hopefully that makes sense. That's all the information I had for hypertension at this point in time. It's not usually a hard topic that's when it comes to assessments, but it's one that's very commonly assessed. And I think knowing these two slides would be really useful from an assessment standpoint. As always, if you have any questions, please feel free to contact me on my email or on Facebook, and I'm always happy to answer them. Or you can leave a comment too, and I'll try my best to get to it. And as always, please look after yourself and please look after your loved ones.